Hi everybody, my name is Dr. Saranya and I'm currently doing my junior residency in ophthalmology from AIIMS Patna. Today we'll be trying to recap virology in less than 30 minutes. So it's like a last look before you actually appear for the entrance exam. So let's start. Now the smallest virus, as you're aware, is the parvovirus. The largest is the pox virus. The arrangement of capsomeres around the genetic material is what decides the symmetry of the virus. Symmetry can either be helical like this one or icosahedral like this one. Now, the symmetry is decided by the capsomeres, whereas the envelope of the virus is usually derived from the cell membrane of the cell that the virus invades, and therefore it is made up of the usual components, the phospholipid bilayer and papilloma proteins. The papilloma proteins are important for attachment to the host cell. All viruses that have helical symmetry will necessarily have an envelope, whereas icosahedral may or may not have an envelope. An exception is the hepatitis B virus. The envelope of the hepatitis B virus is derived from the endoplasmic reticulum of the host cell. Viruses do not have ribosomes except for the arenavirus. Culture of viruses can be done in suckling mice, for example, the arbovirus or the Coxsackie virus, in fertilized hen egg, mind you, amniotic cavity for primary isolation, allantoic cavity for myxovirus, yolk sac for arbovirus, but more importantly, chlamydia and rickettsia, which are two non-viral organisms which can also be cultured in yolk sac. The chorioallantoic membrane is for pox virus, except the molluscum contagiosum virus. We'll be discussing this again. And they show pox of growth. The pox virus shows pox of growth on the chorioallantoic membrane. Cell lines can be used for culture of viruses. Primary, like MK cell line, where fresh cells have to be taken each time to culture the virus. Diploid, like WI38, HL8, MRC5, where the virus can be passed through the same cell line 30 to 40 times. Also continuous, like HeLa from cervical cancer cells, Hep2, McCoy, baby hamster kidney. These are either transformed or cancerous cells. Therefore, indefinite number of passages can be made, but at the same time, they cannot be used for making vaccines because they are cancerous cells. These are the pox of growth produced by the pox virus on chorioallantoic membrane. How to detect viral growth in culture? Immunofluorescence is the best, the most sensitive, and the most specific technique. Others are cytopathic effect, hemadsorption, interference, metabolic inhibition, and transformation. Virus infectivity assay to estimate the total viral count. These can either be physical, with cannot differentiate between infectious and non-infectious viruses, like real-time PCR, antigen detection assay, electron microscopy, or biological, which can differentiate between infectious and non-infectious. For example, plaque and pox, which is quantitative, so you can count the number of plaques and pox you have, or endpoint bioassay, which is qualitative. DNA viruses. All DNA viruses have double-stranded DNA except for parvovirus. So it's too small. It's the smallest pathogenic virus, so too small to even have two strands of DNA. And all of them replicate in the nucleus except the pox virus. So the pox is the largest one. It's too big to even replicate inside the nucleus. It has to come out. But the real reason is that it has its own DNA-dependent RNA polymerase, which is why it does not need the host's DNA-dependent RNA polymerase, so it can replicate in the cytoplasm. Measles and CMV are two viruses that replicate in both cytoplasm as well as in the nucleus of the host cell. Pox virus has complicated symmetry, as can be seen in this picture. No DNA virus has split genome. Herpes viruses, they have a tegument between the capsid around the genetic material and the envelope, and the cytopathic effect produces focal degeneration. There are three families: alpha with types 1, 2, 3, beta with 5, 6, 7, and gamma with 4 and 8. HSV1 lesions are above the waist. Mode of infection is direct contact. Primary infection with the virus produces gingivostomatitis. Latency occurs in the trigeminal ganglion. Reactivates as herpes labialis, cold sore, fever blister. Other primary lesions are dendritic herpetic keratitis, herpetic whitlow, encephalitis, which affects the temporal lobe and is completely treatable, eczema herpeticum, and Molleritz meningitis, which is also known as recurrent lymphocytic meningitis. These are some pictures. This is cold sore or herpes labialis. This is herpetic whitlow. This is the dendritic ulcer produced in herpetic keratitis, and this is eczema herpeticum. HSV2, unlike HSV1, produces lesions below the waist. Mode of infection is sexual. Primary infection is with painful vesicles in the genital area, grouped vesicles on an erythematous base with regional lymphadenopathy. So lymphadenopathy is present. Latency occurs in the sacral ganglion, reactivates as genital herpes, which is actually less severe than primary infection. Neonatal herpes occurs because of infection because of passage through an infected birth canal, and therefore, in cases of mothers infected with HSV, LSCS is actually preferred to prevent infection in the neonate. Diagnosis can be made by de-roofing the vesicle and then scraping the base and performing a Zank smear, which shows multinucleate giant cells like this one. Intranuclear inclusions are of Cauchy A type. The most sensitive way to detect HSV infection is DNA by PCR. Varicella zoster virus produces chickenpox in the young. Incubation period is 4 days. It is a centripetal type of rash with polymorphic rash in crops with a dewdrop on rose petal appearance because of the erythematous base with the vesicle on top. The infections, the scabs are not infectious, so once the lesion scabs over, it's not infectious anymore. Latency occurs in the dorsal root ganglia of T3 to L3, so these are the most common dermatomes involved in reactivation or shingles, which usually happens after the 6th decade because of less immunity. Now, lesions never cross the midline. The most common complication is postherpetic neuralgia. Zoster sign herpes is one type of varicella infection in which there are no vesicles. There's only pain, no vesicles. Shingles can cause Reye's syndrome. Ramsay Hunt is a variant which is a zoster of the facial nerve in which there are vesicles on the tympanic membrane, on the external auditory canal, external auditory canal associated with Bell's palsy. And this is Hutchinson's sign. Presence of vesicles on the tip of the nose indicates involvement of the nasociliary nerve, and this implies that herpes zoster ophthalmicus can soon follow, because if the nasociliary nerve is involved, it means that the ophthalmic division of the trigeminal nerve is also involved. The most common complications in chickenpox, the most common complication is a secondary bacterial infection of the lesions. The most common extracutaneous is encephalitis with ataxia. The most severe is pneumonia. Complications are more in adults. Zostavax prevents these complications. Mind you, it does not prevent infection, it prevents complications. Fetal varicella. Varicella in the fetus happens when the infection happens in the first 20 weeks of pregnancy, with cicatrizing skin lesions and limb atrophies can be seen in this picture. Neonatal varicella, on the other hand, happens when infection happens before 7 days to after 2 days of delivery in the mother, and disseminated disease with generalized vesicles is present in neonatal varicella. Prophylaxis can be done with Varivax, which is a live attenuated type of vaccine using the OCA strain. Human herpes virus 4 or Epstein-Barr virus infects B cells, the receptor being CD21 or CR2 or C3. Transmission is through blood, saliva, bone marrow, not sexual. That's important to remember. Peripheral smear shows atypical lymphocytes or downy cells with a typical ballerina skirt appearance. Now, what is important to remember is that Epstein-Barr virus infects the B cells, but the atypical cells which are seen in a peripheral smear are actually cytotoxic T cells. Clinical features of infectious mononucleosis, we're all aware of this: fever, sore throat, lymphadenopathy, subclinical hepatitis, encephalitis, rash. This rash aggravates after administration of ampicillin or amoxicillin. This was a question in the last INI-CT. Burkitt's lymphoma with translocation T814, c-MYC mutation, oral hairy leukoplakia, which is a non-malignant lesion on the lateral border of the tongue in HIV patients, nasopharyngeal carcinoma, PTLD, post-transplant lymphoproliferative disorder, the most common being primary CNS lymphoma, Hodgkin's disease, and Duncan's disease. Duncan's disease is a fatal X-linked infectious mononucleosis because of mutation of a signal transduction protein of T cells and NK cells. Diagnosis can be done by IgM against viral capsid antigen, IgM against early antigen, which indicates current infection, IgM against Epstein-Barr nuclear antigen, which indicates past infection. Heterophile antigen detection, monospot, which is a really rapid test, but the best one is still nucleic acid hybridization test. Cytomegalovirus or HHV5, it remains latent in salivary glands, in kidneys, and in various other tissues, and produces enlargement of the infected cells, which is why it is also known as the cytomegalovirus. The disease in immunocompetent individuals resembles infectious mononucleosis but is heterophile negative, unlike actual infectious mononucleosis. Peripheral smear does show atypical lymphocytes just like infectious mononucleosis. In pregnancy, it's the most common agent showing vertical transmission. The fetus shows blueberry muffin appearance with typical petechial rash along with periventricular calcifications. Prenatal diagnosis is by culture or PCR of amniotic fluid. Postnatal can be done using PCR, the best sample for which is either saliva or cord blood, or culture, the best sample for which is urine or saliva. This is just to compare the various kinds of calcifications produced by different viruses after vertical transmission: subcortical by Zika, diffuse by Toxoplasma, and periventricular by CMV infections. You can just take a screenshot to compare the different kinds of calcifications. CMV in HIV is the most common is the most common opportunistic infection, and the most common uh, cause of blindness in HIV infection is actually CMV chorioretinitis with a typical pizza pie appearance with extensive hemorrhages and exudates. The infection occurs when CD4 count is below 50 per microliter. If not chorioretinitis, the most common extraocular manifestation is polyneuropathy. CMV in transplant patients, again the most common virus causing opportunistic infection in transplant patients, maximum risk in the first 1 to 4 months. The important complications are esophagitis, hepatitis if liver transplant has occurred, interstitial pneumonia in case of lung transplant patients. CMV is present in all body fluids, so there are multiple modes of transmission, including breastfeeding. Antigen detection, you can detect the PP65 antigen by ELISA. Intranuclear inclusions have atypical outside appearance. Two resistances which are important to remember are UL97 phosphotransferase mutation producing ganciclovir resistance and UL54 mutation producing resistance to ganciclovir, cidofovir, and foscarnet, which is quite extensive. HHV6 latency in BT NK cells in childhood, primary infection produces roseola infantum, whereas in adults it produces exanthem subitum, which literally translates into sudden rash, so like a sudden eruption, fever with seizures. Reactivation leads to pneumonia and focal encephalitis. Type 7 also produces fever with seizures. Type 8 produces Kaposi sarcoma, which is an AIDS-defining tumor of the endothelial cells with this typical purplish tumor-like appearance. A new FDA-approved drug for Kaposi sarcoma is pomalidomide, an anti-angiogenic thalidomide derivative. It produces tumors by inhibiting P53, so it prevents apoptosis. The other manifestations are multicentric Castleman's disease and primary effusion lymphoma. Hepatitis viruses, a small mnemonic that can be used to actually remember the families are private hospitals favor rich clients. That's type A, B, C, D, and E. Picornavirus, HepDNA, Flavi, RNA or delta agent, and Calicivirus. DNA is only present in the genome of the hepatitis B virus. Only types B, C, and D have an envelope. A is the only one that's cultivable, and A has a vaccine that is formalin inactivated. A has a vaccine that is formalin inactivated. Type B has a vaccine that we're all aware of, and Type E has a formalin inactivated vaccine, HIV 239, which is available only in China. Hepatitis A virus is the most common cause of sporadic hepatitis in kids. It causes infectious hepatitis through water and shellfish. So if the question mentions water, shellfish, features of hepatitis in kids, it's likely to be hepatitis A. Incubation period is 15 to 45 days. And there are two linear strands of DNA in hepatitis B virus. One is a plus or an incomplete strand, and one is a minus or a complete strand. DNA polymerase is also of two types. One is a DNA-dependent DNA polymerase, one is an RNA-dependent reverse transcriptase. And there are two forms in which the virus can exist. One is 22 nanometer sphere, one is a 22 nanometer filament. These are non-infectious because they lack nucleic acid, and these actually form the HBsAg antigen. The infectious one is the 42 nanometer Dane particle. Genes are P for polymerase, C for PC for envelope, S for surface. S shows an escape mutation or an A mutation. X is what inactivates P53, so if it gets integrated with the host genome, it has no plastic and will pass. Markers in hepatitis B infection. The first marker is HBsAg. HBc is never detected in serum, so if it's an option in the MCQ, it's likely not to be the answer because it's never detected in serum. HBeAg is a qualitative marker of replication, so if it's present, you can just say replication is going on, but you not quantify the replication. Anti-HBc is the first antibody to appear if it's of IgM type. That makes it the best marker. Anti-HBe indicates reduced replication because HBeAg indicates replication unless it's a pre-COVID, in which case the change of codon is from UGG to UGA. Anti-HBs is protective, is the only antibody in vaccinated individuals. HBV DNA is a quantitative marker. So HBV DNA present, the more replication that's going on. The only marker in the window period is IgM anti-HBc. HCV, the most common cause of transfusion-related hepatitis in developed countries, is Hep C, not Hep B. The reason we don't have a vaccine against it is antigenic variation. It was associated with autoimmune features leading to microbiomia, and the renal pathology is MPGN. It has the maximum risk of maximum is with Hep B. The maximum risk is with Hep C, 80%. Hepatitis D does not have genes for the envelope, so it relies on hepatitis B for replication. Co-infection, that is both infections together, is actually less severe, whereas superinfection, D for D, just like in the alphabet also, is actually more fulminant. ATV is most common cause of hepatitis in kids, E is in adults. It is also known as NEB or non-NEB epidemic or enteric virus. It is not associated with carrier state or chronicity. The incidence of disease is not in normal population, which goes up by 10 times in pregnancy to 10 to 20%. Adenovirus, it is a space satellite shaped virus with 47 serotypes. The cytotoxic effect that it produces is surrounding application. The various serotypes which are associated with specific disease are 3, 7, and 14 for pharyngoconjunctival fever, 8, 19, and 37 for epidemic keratoconjunctivitis, 11 and 21 for hemorrhagic cystitis, 40, 41 for diarrhea, 3, 4, and 7 for acute respiratory disease. Parvovirus. The receptor is the P antigen which is present on erythroblasts. Mind you, not erythrocytes, on erythroblasts. It is the smallest pathogenic virus. In infants, it produces typical fifth disease with perioral sparing and a lacy reticular rash on the body with a slapped cheek appearance. In adults, it produces painful pruritic gloves and stocking syndrome, which is actually a type 3 hypersensitivity. In cases of RBC turnover states, in high RBC turnover states like sickle cell anemia or thalassemia, it produces a transient aplastic crisis because of extensive hemolysis. In immunocompromised states, it leads to pure red cell aplasia, and in transplacental infection, it leads to non-immune hydrops. Pox virus. The smallpox virus was eradicated because of various reasons like an absence of reservoir, an absence of carrier state, typical clinical features leading to fast diagnosis, and an effective vaccine. Vaccinia obtained by serial subculture of cowpox virus is present in the smallpox vaccine. Molluscum contagiosum is non-cultivable. In adults, it produces polyumbilicated lesions in the genitals. In children, it produces similar lesions on the face. The intracytoplasmic inclusion bodies are known as Henderson-Patterson bodies. These are the typical polyumbilicated lesions seen in infection with molluscum contagiosum. HPV or human papillomavirus is also non-cultivable, just like molluscum contagiosum. It infects squamous epithelium, producing vacuoles and leading to typical cells known as colocytes. The proteins are early ones like E6 inactivating P53, E7 inactivating retinoblastoma. These are both tumor suppressor genes, so it leads to uncontrolled proliferation, leading to wart formation. Late ones like L1 and L2 are capsid proteins. L1 is a component of the vaccine. This was again a question in the last INICT. The lesions are condyloma acuminata, the most common sexually transmitted disease worldwide. Common warts are produced by types 1, 2, 3, 4. Any female with genital warts is likely to pass on the infection to a child if the child is born by normal delivery, and in this case the child will suffer from recurrent laryngeal papillomatosis, the treatment for which is cidofovir. This is a picture of Treeman syndrome or epidermodysplasia verruciformis with an unusual number of warts on the hands, which produces an appearance like a tree, and it happens because of chromosome 17 mutation. POLYOMA virus is the John Cunningham virus. If it gets reactivated in immunosuppressed individuals, the virus crosses the blood-brain barrier to infect astrocytes and oligodendrocytes to produce progressive multifocal leukoencephalopathy. And BK virus, in case of renal transplant patients, causes interstitial nephritis. In case of bone marrow transplant patient, causes hemorrhagic cystitis, and urine in such patients shows the presence of decoy cell casts. RNA viruses. We'll start with RNA viruses now. All RNA viruses have single-stranded RNA except the Riovirus. Segmented genome is present in ROBA, Rio, Ortho, Bunia, and Arena, and they can exchange these segments to form new antigens, and therefore by genetic reassortment they can lead to antigenic shift. Baltimore classification is based on replication, classifies it into 7 groups. Positive and negative sense RNA viruses. Positive sense viruses are those that perform direct translation, that's DNA to RNA, whereas negative sense are those which first have to use RNA-dependent RNA polymerase to first make a positive sense RNA and then translate. All negative sense viruses have helical symmetry. Now, a mnemonic that can be used to remember the negative sense viruses or the viruses that have negative sense RNA are always bring polymerase or failed reaction. This is Himanshu's own mnemonic. That's arenavirus, Bunia virus, paramyxo, orthomyxo, phyllo, and rhabdovirus. Myxovirus. Myxo stands for mucin, so they have an affinity for the mucins of the respiratory epithelium. The various peplomas or proteins are H-hemagglutinin, which attaches to the neuraminic acid receptor, so it initiates infection. It is of 16 types. N or neuraminidase. So neuraminidase indicates that it cleaves the neuraminic receptor. So it's also the neuraminic acid receptor. So it is also known as the receptor destroying enzyme or the eluting enzyme. F or fusion protein, which is present only in paramyxo, it's absent in orthomyxo. And H and N are the two antigens that actually show antigenic variation. F does not show antigenic variation. Orthomyxovirus has 8 segments in the genome, 3 types based on the ribonucleoprotein are A, B, C. B is associated with bowel. So B for bowel is associated with bowel symptoms. A shows epidemics and pandemics, that's shift and drift, whereas C is non-pathogenic. Diagnosis: antigen can be detected by hemagglutination. Antibody against the influenza virus can be detected by hemagglutination inhibition. Paramyxovirus, the various diseases that can cause, firstly, measles. The typical way in which measles progresses is fever appears on day 10 of infection, followed by Koplik spots. Koplik spots are small reddish spots on a small whitish blue spots on a reddish base opposite the lower second molar, which appear on day 12, followed by a maculopapular rash on day 14. It first appears behind the ear and then spreads to the rest of the body and then disappears in the exact same order. The characteristic cells are Watson-Finkeldy giant cells in measles. The rarest complication that can occur, but also the most severe one, is subacute sclerosing panencephalitis, whereas the most severe among the common complications is pneumonia. The vaccine against measles uses the Edmonton Zagreb strain. Mumps, the most common manifestation is parotitis, others being aseptic meningitis, orchitis, but orchitis is usually unilateral, so mumps does not lead to sterility, and the strain in the vaccine is Geraldin. Respiratory syncytial virus is the most common cause of bronchiolitis and pneumonia in infants producing bilateral wheeze. It has only the F protein, not H and N. It has only F. F protein is targeted by palivizumab and is used for prophylaxis of acute disease, whereas for treatment, the drug that is used is ribavirin. Parainfluenza produces laryngotracheobronchitis with stridor. So RSV is associated with wheeze, whereas parainfluenza is associated with stridor and barking cough, a very typical barking cough. Picornavirus. Picornavirus, the various viruses under picornavirus are poliovirus, enterovirus and echovirus, rhinovirus, calicivirus, and hepatitis A virus. So it can be remembered by the mnemonic perch. Enterovirus is the important ones, the AHC or Apollo conjunctivitis. 71 producing AHC is acute hemorrhagic conjunctivitis. 71 produces hand, foot, and mouth disease. 72 is hepatitis A virus. Echo produces aseptic meningitis. Coxsackie, there are two types, A and B. Coxsackie B produces pleurodynia or Bornholm's disease or devil's grip, which is known as epidemic myalgia with severe muscle pain. Both of them produce aseptic meningitis. Coxsackie A, just like enterovirus 70, also produces acute hemorrhagic conjunctivitis. Rhinovirus is the most common cause of common cold, and there are more than 100 serotypes, so vaccination against rhinovirus is not possible. Poliovirus, fecal-oral transmission also by respiratory droplets. Out of all the cases of poliovirus infection, only 2% actually progress to paralytic polio. The earliest change that is seen in the case of paralytic polio is chromatolysis or nasal body degeneration of the anterior horn cells with or without meningoencephalitis. Type 2 was eradicated in 2015, type 3 was eradicated in 2019. Retrovirus, there are two subfamilies, Oncoviridae and Lentoviridae, and Lentiviridae is much more important. So, coming to Lentiviridae, there are various subtypes from A to K except I and E based on glycoprotein 120. That is the basis of the classification. Type C is most common in India, transmitted heterosexually, whereas B is more common in the West, transmitted homosexually. The enzymes are reverse transcriptase, integrase, protease. The genes, the structural genes are GAG, which encodes P17, which is the shell protein outside, P24, which is the coprotein inside. POL encodes the enzymes. E and B, it encodes glycoprotein 16, which actually gets split by this protease enzyme into GP120 and 41. GP120 is what attaches to the CD4 on the T helper cells and macrophages of the host cell. whereas GP41 is responsible for the fusion. So GP120 attaches and 41 is responsible for the fusion. Now, there are co-receptors, for example, CXCR4, which is lytic, that is, it lyses the host cell and releases the new viral particles, and CCR5, which is a transmitting kind of co-receptor. These were the structural genes, that is GAG, POL, and ENV. Non-structural genes are TAT, REV, NEF. NEF is important because it actually reduces MHC1 expression on the virus infected cells and therefore reduces the chances of cell death of these cells. VIF inhibits ApoBeg3G and therefore causes hypermutation of the retroviral DNA and increases infectivity. VPR transports the viral core and therefore is important in latent infection. And the last one is VPU. Transmission, sexual transmission is most common, but the risk is actually low. Transplacental infection is again possible. So just like HSV infection, we prefer LSCS in such a case. It is transmitted through breast milk. It is transmitted through blood transfusion, where the risk is maximum, but because monitoring is done carefully, the incidence is really less. In the window period, that is from infection to detection of infection, or that is from infection to actual manifestation, diagnosis can be made by detecting P24. Later on in the course of the disease, to diagnose, Western blot is confirmatory, whereas gold standard is always PCR. DNA PCR is diagnostic, so D for DNA is diagnostic, whereas RNA PCR is prognostic. Progression of the disease can be assessed in two ways, most commonly by doing a CD4 count by flow cytometry. A reducing CD4 count indicates that the disease is progressing, it's not under control, whereas the best way is actually to do a complete viral load by RNA PCR to get an actual idea of the disease. Arboviruses, these are usually transmitted by insect vectors. The first one is Toga virus. The various infections transmitted by Toga virus are chikungunya, and the vector is Aedes aegypti. Aedes mosquito also transmits dengue. It also transmits Rift Valley fever and yellow fever. This is chick sign on the nose, that is hyperpigmentation on the nose, typically seen in chikungunya along with fever and arthritis. Rubella, or third day measles or German measles, it does not have a vector. So it's an arbovirus but does not have an insect vector. Fever, rash, again blueberry muffin appearance, just like fetal CMV infection. These are Forshamer spots which are seen on the palate in case of rubella, but again these are not pathognomic because they may be seen in measles as well. The most serious complication is encephalitis. It interferes with the cytopathic effect of ecovirus. Congenital rubella, it's a triad of sensorineural hearing loss, patent ductus arteriosus, and bilateral pearly white nuclear cataract. Out of all these, the single most important is sensorineural hearing loss. Maximum damage occurs if infection occurs in the first trimester. If infection occurs beyond 16 weeks of gestation, there is no such risk. Flaviviruses, dengue, there are 5 serotypes, out of which 2 is most dangerous. The rash in dengue is also known as white islands in a sea of red. Yellow fever, the incubation period is 3 to 6 days. It produces intranuclear inclusion bodies known as Councilman or Taurus bodies. In India, we have the vector, that is Aedes aegypti, but we do not have the disease. So ideally, the Aedes aegypti index should be less than 1% in India. The vaccine is a 17-day live attenuated vaccine using a CB strain. In case of Japanese encephalitis, pigs are the amplifier. They need to be vaccinated. RD birds like herons are the reservoir. Man is a dead-end host. The vector is the Culex mosquito, Culex tritaniorhynchus or Culex vishnui. Chiasano forest disease. Man is again the dead-end host, and the vector is a hard tick, the name of which is Haemaphysalis spinigera. Rotavirus. Rotavirus is not an envelope virus. It is the most common cause of infantile diarrhea, mostly infecting children between 6 to 24 months of age. It has 2 capsids, so it's also known as a double shield virus. It has double-stranded RNA, so again, since it's a reovirus, it has 2 RNA strands with 11 segments. The enterotoxin is non-structural protein 4. It produces watery, non-bloody diarrhea, so no blood in the diarrhea and no blood in the stool. And fecal-oral transmission, however, clean water and hygiene is not useful in preventing rotavirus infection. Calicivirus, a non-Bob virus, produces viral gastroenteritis in adults. The most common cause in adults is calicivirus, and the source is usually shellfish. If the question mentions ships and gastroenteritis in adults traveling in ships, the cause is likely to be calicivirus. Rabies, the POLYOMA, that in case of rabies that attaches to the host cell, they are G protein spikes. Babes nodules are lymphocytic aggregations seen in CNS tissue. Antemortem diagnosis can be done by detecting antigen from nape hair follicles or corneal scrapings, or antibody by immunofluorescence in fluids like CSF or serum. RT-PCR is again highly sensitive and specific, whereas post-mortem diagnosis can be done by brain biopsy. The usual locations from which biopsy can be taken are pyramidal neurons of the hippocampus or Purkinje cells of the cerebellum, which characteristically show Negri bodies in the cytoplasm by using cellular stain. Negri bodies, there are two kinds of rabies, street and fixed. It's produced only by street rabies, not by fixed rabies. This picture shows Babe's nodules, which are lymphocyte aggregates, and this picture shows Negri bodies. Zika virus transmitted by Aedes. It can also be transmitted by Mansonia or Culex mosquitoes. Now, Zika produces conjunctivitis, which actually helps it to differentiate from dengue and chikungunya, which have similar clinical features. Infection in pregnancy very characteristically leads to microcephaly in the child with subcortical calcification. We have seen a picture before this. Filovirus, the important ones, Ebola virus, Zaire strain has 90% fatality. A new drug for filovirus is Inmazep, which is a combination of three monoclonal antibodies, atoltevimab, maftivimab, and odesivimab. Diagnosis can be done by antigen detection against NP, GP, and VP40, or antibody detection against NP and GP. Coronavirus, hot topic. It's a beta coronavirus with single-stranded RNA, positive sense RNA, helical symmetry. It's an envelope virus. Now, viruses that have envelopes usually do not cause diarrhea because the envelope gets lysed by bile salts. Coronavirus is an envelope virus that still causes diarrhea. Size 125 nanometer, and it has 74 glycoprotein spikes made up of hemagglutinin esteres. The genes which are important are M, a membrane glycoprotein forming envelope, and it's important in budding. E for envelope, N for nucleocapsid, it actually interferes with host immunity. S for spike protein, now it binds to the ACE2 receptor and it enters using the TMPRSS2 receptor, so the two are different for binding and entering. And S1, it's of two types, S1 and S2. S1 binds, S2 helps in fusion. ORF and RDRP, that's RNA-dependent RNA polymerase. The drug remdesivir, which is so useful in case of coronavirus infection, actually inhibits the RDRP. The window period is 0 to 7 days. RT-PCR in that period is best for detection. IgG becomes positive on day 14. RT-PCR is said to be positive if nucleic acid amplification test is positive for at least two different targets on the SARS genome, or one NAT is positive for beta coronavirus, or the virus is further identified by sequencing of the genome. Culture needs biosafety levels 3, RT-PCR needs biosafety levels 2. Incubation period, it ranges from 1 to 14 days, whereas median incubation period ranges from 4 to 6 days. An indigenous test kit developed in India for detecting IgG antibodies is Kavach ELISA, whereas the newest paper-based test kit known as Feluda, which is an acronym for FN-Cas9 editor-linked uniform detection assay, uses CRISPR technology and gives results in less than 30 minutes. Clinical features of COVID, we just go over it. The early phase is when the virus just binds to respiratory epithelium and gains entry, followed by a pulmonary phase where it actually binds to type 2 pneumocytes, producing ARDS and hypoxemia. But the problem is that the peripheral chemoreceptors have also been invaded by the virus. So there is no hyperventilation despite low oxygen saturation, and this is known as happy hypoxemia. If the pulmonary phase progresses to a phase of severe hyperinflammation that happens when there is a cytokine storm, the most important cytokine being interleukin 6. The two indications of severe disease are lymphopenia and raised D-dimer levels. Presence of APOL1 gene increases the risk of something known as collapsing nephropathy. The vaccines which are available are mRNA based like Pfizer and Moderna. In India, we have Covishield, which is a non-replicating viral vector, and Covaxin, which is an inactivated vaccine. We'll just go over two small things before we end. Nuclear inclusion bodies. Cauchy A type are seen in HSV and VZV infection. Cauchy B in adenovirus and poliovirus infection. Aulies and CAV in Taurus bodies in yellow fever. These are nuclear. Cytoplasmic includes inclusion bodies are Negri bodies. Also, the Henderson-Patterson bodies are also cytoplasmic inclusion bodies. That's all for today. Thank you so much for watching, and all the best for your exam.